Welcome back to our Community Medicine Revision series. Today's hot topic is Randomized Controlled Trials, also called the RCT. Dr. Joshi, could you start us off with a crisp definition and why RCTs matter for exams?
An RCT is an epidemiologic experiment where eligible participants are randomly allocated to an intervention group or a control group, then followed to compare outcomes. Random allocation, a suitable control, often placebo or standard of care, and blinding are its three essentials. RCTs are considered the apex for evaluating interventions because they best minimize bias and support causal inference.
Great. Let's unpack the randomization bit. Students often ask, what exactly does randomization achieve and how?
Randomization ensures each subject has an equal, though unknown in advance, chance of assignment to any group. Practically, we use random number tables or computer generators with procedures like sequentially numbered opaque, sealed envelopes. The big win is internal validity. Randomization balances known and unknown prognostic factors across groups and helps eliminate selection bias.
Paul and recall. What type of bias does randomization primarily prevent?
Selection bias. Randomization is the heart of an RCT precisely because it prevents preferential allocation and produces comparable groups, guarding against confounding.
Now, blinding is the second essential. Dr. Joshi, walk us through single, double, and triple blinding and toss in allocation concealment while you're at it.
Single blinding means participants do not know their assignment. Double blinding means participants and investigators assessing outcomes are unaware. Triple blinding extends to the data analyst as well. Allocation concealment is closely related. It prevents foreknowledge of upcoming assignments at the moment of enrollment, often via sealed coded systems, so recruiters cannot manipulate who enters which arm. Together, these mechanisms reduce performance and measurement biases.
Case Vignette 1. A new antihypertensive is compared with placebo for 1 month. Patients and treating physicians are unaware of assignment, and blood pressure is measured at the end. Identify the design features you hear.
That is a randomized prospective clinical trial with double blinding and a placebo control. It embodies random allocation, concealment of assignment during follow-up, and objective outcome measurement.
Pause and recall. Why is a placebo made to look, smell, and taste like the real drug?
To preserve blinding and avoid expectancy effects in participants and assessors, placebo should be indistinguishable to keep perceptions from influencing reporting or measurement.
Let us zoom out to the typical step-by-step flow of an RCT. What sequence should students reproduce in answers?
Start with a protocol, choose reference and study populations, apply inclusion and exclusion criteria, randomize, deliver the intervention versus control, ensure follow-up, and assess outcomes at pre-specified endpoints. That is the classic flow diagram of RCT conduct.
Nicely structured. Methods aside, where do clinical trial phases fit in? Many exam questions test phase 1 to phase 4.
Phases describe drug development. Phase 1 explores dose and initial safety, often in small groups. Phase 2 studies pharmacokinetics and pharmacodynamics in patients. Phase 3 is the definitive randomized controlled stage, comparing new treatment against standard or placebo. Phase 4 is post-marketing surveillance of effectiveness and rare adverse events.
And what about equivalence or non-inferiority ideas? They pop up in vivas sometimes.
When an effective standard exists, we might test whether a new intervention is no worse than the standard by a pre-specified margin D. You can't prove two therapies identical, rather you show the observed difference lies within that clinically acceptable margin. This is the logic of equivalence or non-inferiority trials.
Let us diversify designs. Beyond simple parallel groups, what else should students recall?
Factorial trials test more than one intervention simultaneously. Think 2x2 designs, such as aspirin and beta-carotene tested together in physicians, enabling efficiency if interactions are limited. Community or cluster randomized trials randomize groups like villages or schools rather than individuals. They're used for community-wide interventions, though they demand larger samples and careful analysis.
Case Vignette 2. A district plans to reduce salt intake using village cooking demonstrations and policy nudges. Villages are randomized to intervention or usual practice, and household blood pressure is measured after 6 months. What design? What special issues?
That is a cluster randomized community intervention trial. Special issues include intra-cluster correlation, individuals within a village resemble one another, need for larger sample sizes, and standardized delivery of the program across clusters. Ethical approvals, informed community consent, and clear outcome definitions are vital.
Quick pit stop on analysis. In exams, the term intention to treat often shows up. What should they say?
Intention to treat means analyze participants in the groups to which they were originally randomized, regardless of protocol deviations or non-adherence. It preserves the benefit of randomization and provides a pragmatic estimate of effectiveness. It's the standard approach in RCTs.
Pause and recall. If several participants switch arms mid-trial, do we reassign them in analysis?
No. Keep them in their original groups for the primary analysis. Classic intention to treat.
Let us talk bias and validity. Even the gold standard is not flawless, right?
Correct. RCTs minimize many biases but do not eliminate all. Practical challenges include maintaining blinding, losses to follow-up, and external validity. The highly selected trial population may not represent all patients. Moreover, results can take time to accrue for outcomes that develop slowly. Hence, we combine RCTs with other evidence and use meta-analysis and cost-effectiveness where appropriate.
Ethics next. What are the exam-worthy anchors before launching an RCT?
A written protocol, scientific justifications, ethics committee approval, genuine clinical equipoise, informed consent, confidentiality safeguards, and provisions for safety monitoring. It's considered unethical to introduce therapies into routine practice without sound evidence. History has taught us hard lessons.
Practicalities during conduct. What exam bullets should students list to show they can run an RCT?
Ensure robust random sequence generation and allocation concealment. Standardize intervention and placebo, shape, color, taste. Plan compliance checks or pill counts or metabolite testing. Apply blinding where feasible. Schedule follow-up visits and predefine objective outcome measures and timelines. Then analyze and report according to a pre-specified plan.
Quick apply level question. Suppose we can't blind in a surgical trial. What can we still do to limit bias?
Use independent outcome assessors blinded to group, make outcomes as objective as possible, and maintain allocation concealment up to the point of assignment. These steps reduce observer and performance biases even when blinding the operators in practical.
Final high-yield reminders before we close?
3 take-home lines. Randomization plus allocation concealment prevents selection bias and underpins internal validity. Blinding, single, double, or triple, limits performance and measurement biases. Analyze by intention to treat and describe your protocol and flow clearly in the exam. For scope, remember designs like Factorial and cluster randomized trials and know the clinical phases. If asked why RCTs are prized, they're our best tool to draw causal inferences when ethically and practically done well.
Pause and recall. List the 6 classic steps of an RCT, protocol to outcome assessment. If you could do that smoothly, you're exam ready. Dr. Joshi, thank you for demystifying RCTs with structure and stories.
My pleasure. Keep practicing structuring your answers, definition, essentials, steps, bias control, analysis, and ethics, and you'll handle any RCT question with confidence.